Good morning, everybody, and welcome to the Spectrum's first research forum. I'm Satya Rao. I'm the Executive Clinical Director of Spectrum, and I'll be a host for the morning session today. Before we commence, I begin today by acknowledging the traditional owners of the land on which we meet today and pay my respects to their elders, past, present, and emerging. I extend that respect to Aboriginal and Torres Strait Islander peoples who may be here with us today. I would also like to recognize all people with lived experience of trauma, neurodiversity, mental ill health, and substance use or addiction, and their families, carers, and supporters. This recognition extends to the clinical and non-clinical workforces that support people with lived experience, their families, and carers. For those of you who may not be familiar with Spectrum, Spectrum is a center of excellence and a statewide specialist service for personality disorders. And now we are also moving on to include complex trauma related disorders as well. Okay, now we have a very exciting and jam-packed program for you today. And we will have two keynote presentations, a full afternoon session of rapid fire research paper presentations, and we'll also discuss our future research strategy. I'm now honored to welcome Adjunct Professor David Plunkett, our Chief Executive Officer at Eastern Health, and who will open the forum with a welcome address. David joined Eastern Health in 2002 and has held various roles, including Chief Nursing and Midwifery Officer and Executive Director of Acute Health, all leading to his current role of Eastern Health Chief Executive since September 2016. We are extremely grateful to you, David, so that you could be here with us today. Over to you, David. Thank you.
Thank you very much, Satya, and thank you for your very warm welcome. I too would like to acknowledge the traditional owners of the land upon which the forum is being hosted today and pay my respects to elders past, present and emerging. Thank you for doing that, and welcome everyone to Spectrum's inaugural research forum. A wonderful occasion as it is. There are more than 250 registrants who have come from universities, mental health services, non-government organisations, both in Victoria, in Australia, and really pleased to say that we have registrants from Japan, Canada, and also Puerto Rico. So welcome everybody to today's really important event for showcasing research in this vital area of personality disorder and trauma. I too would like to welcome all those who are with us today who have lived experience, to the researchers, to clinicians, to friends, families, to the Spectrum team, to the Turning Point team, and also the broader Eastern Health team. Welcome and thank you for all that you do to make this system and this service what it is today. I also like to welcome two really vital and important keynote speakers here. The first being in Professor Bryn Grenier from Project AIR at Wollongong University, and Professor Suresh Sundram, who is the head of psychiatry at Monash University, and I'm sure that they will give incredibly powerful and insightful presentations, so thank you for that. Spectrum is well known for its training and clinical expertise, as Satya has mentioned, in the treatment of personality disorder, and with requests for training, consultation and treatment come not only from Victoria, but in fact right across the country. And I think that that demonstrates just the importance of a service such as Spectrum in being able to support not only our service providers, but also those who experience our service and families as well. Spectrum has recently conducted a national training strategy, having provided training to all states and territories to upskill clinicians and services in evidence-based psychological treatment and care of people who are living with personality disorder. And that complements then and feeds into the purpose of this forum, which is to provide a platform for showcasing the diverse and groundbreaking research that Spectrum is conducting in the field of personality disorder. Spectrum's experience and insights, which you know have been gathered from over more than 20 years, will be clearly highlighted within the research program that you will be hearing about today. Spectrum works in collaboration and is a partner to many, and does that extensively. And the training example that I gave before is just one of those collaborations. But it's also with mental health services, with universities, with consumer organisations, and in fact with government departments, to highlight the important insights that have been learnt from the field, and to turn these into and strengthen the advocacy for the need for more training and improved training and resourcing that our sector so desperately needs. For those who are in Victoria, we clearly know from the Royal Commission the need for further investment in this space, particularly for those who have experienced complex trauma. And so really, really pleased that Eastern Health is able to continue to support Spectrum to undertake further research and strengthen its expertise for those people who have experienced complex trauma. On behalf of the Eastern Health Board and the executive, I would like to extend my best wishes to you all, and trust that you will find today's presentations inspiring and stimulating. Thank you all and enjoy the forum. Thanks, Sathya.
So thank you, David. Thanks for that warm welcome. And it's been a real honor to have you here with us today. Thank you. Now, I shall provide a brief overview and highlights of Spectrum research and innovation activities. And soon after my presentation, my colleague, Associate Professor Gillian Broadbeer, will provide a more detailed account of our research and innovation activities. So the main activity pillars of Spectrum include the clinical activities, the workforce development training activities, and research and innovation activities. With a strong foundation held by values that guide us in all our activities, which is what makes us what we are today. We pride ourselves as a value-based organization, and we put our patients first. We take up leadership and advocacy in the field of complex trauma and personality disorder. We work closely with the consumer and carers in collaboration with the Australian BPD Foundation, led by Rita Brown, and other consumer and carer organizations. Our overarching objective is to improve the outcomes for people with complex trauma and personality disorder. I will highlight a few of our important research outputs. We investigated the Victorian coronial data for personality disorder related suicides for a 5-year period and demonstrated that, unfortunately, on an average, there is 1 BPD suicide per week in Victoria. 99% of them have had contact with public mental services in the preceding 1 year before death. This paper was one of the triggers for a $10 million investment by DHHS to enhance capacity within the mental services. Result of that study was the Personality Disorder Initiative, which involves training and building embedded capacity within the local mental services. And we chose 6 mental services to trial, and it's a 4-year project, and we are currently in the end of stage 2 training. So this is one demonstration of how Spectrum research has triggered change in practice in the state of Victoria via advocacy. We also innovated a method of suicide and self-injury assessment method and published our findings. The Spectrum method of risk assessment was incorporated within the NHMRC clinical practice guidelines. We have evaluated our treatment outcomes for Spectrum at 12 and 18 months follow-up. The 12-month data shows improvements in clinical symptoms as well as quality of life, also reduction in self-harm acts and suicide attempts. So we see people who received treatment from us maintaining clinical remission even at 18 months follow-up. We have innovated a brief treatment, a brief group treatment that is intensive. It involves a 10-week program and with 80 hours of psychological treatment built within the 10 weeks. And we have evaluated this treatment, and it shows that significant symptomatic improvements even at the end of 10 weeks. We have published a paper highlighting the presence of BPD in old age, and this triggered extending our care to people beyond 64 years of age. Until then, we only worked with people from 16 to 64 years of age, again highlighting how our research activities have informed and changed clinical practice in Victoria. We did an audit and demonstrated that we prescribe psychotropic medications excessively for people with personality disorders, despite knowing that there are no medicines that are patented or indicated for treatment of borderline personality disorder. So we have strongly advocated for changes in our prescribing patterns and incorporated this message in our training activities across Victoria. We have been running conferences that attract participation from across Australia and in the recent years more globally. As some of you may be aware, there have been some important developments recently. Consumer and care advocacy has clearly taken off, especially in the Australian context, certainly in Victoria. The Royal Commission reform into mental health in Victoria has made some important recommendations, with the Victorian government accepting and funding for all of them. We hope to see some significant improvements in access to treatment for people with personality disorders and complex trauma disorders in Victoria. There have also been changes in the field. In ICD-11, for example, has conceptualized personality disorder as a unitary diagnosis, and we've done away with the categorical approach, which is a major change and improvement. And complex post-traumatic stress disorder has been added as a new diagnosis. And common factors approach is becoming more and more accepted and researched. Brief treatments are becoming popular and evidence is gathering. And there's also excitement in researchers about the possible novel biological approaches, such as use of psychedelics and transcranial magnetic stimulation. With this background, Spectrum has developed a strategic plan for research, which will be released today. And as part of this plan, we wish to reframe and consolidate our research and innovation efforts under a new center for personality disorder and complex trauma research. And we are launching the center today. So as per a new research strategic plan, we will be working more closely with lived experience workforce. We will further focus on translational research, generating evidence to inform practice. We will innovate treatments, focus on understanding and developing treatment for complex trauma related disorders such as complex PTSD. And we would also work on proposing a model of care for Victoria. This is especially important in the light of the Royal Commission reform changes. We'll focus on suicide prevention strategies, and we'll prioritize developing position statements, guidelines, and inform policy. I'll conclude by thanking our lived experience people who have been passionate advocates at Spectrum. Thank you. I would now like to introduce a close colleague of mine and the head of research and innovation here at Spectrum, Associate Professor Gillian Broadbear, to talk about Spectrum Research Program. Gillian holds a PhD in biopsychology from the University of Michigan and has spent many years working in the substance abuse field, conducting preclinical and clinical research. She has done a lot of lab research in the past, and Gillian is passionate about conducting research that can be used for education and advocacy to improve our understanding and the resourcing of services to assist everyone whose lives are affected by personality disorder. Welcome, Gillian.
It's my great pleasure and privilege to speak with you today and present this overview of Spectrum's research journey. From humble beginnings, Spectrum has grown to become an organisation respected for its contributions to and leadership within the personality disorder field. Now, Spectrum was never intended to become a research organisation. Its primarily clinical focus was a response to the dire need for treatment and expertise in personality disorder, which was lacking in Victoria at the time. The development of a research culture within Spectrum is somewhat remarkable given its lack of resources. However, recognition of the need for Spectrum, the Personality Disorder Service for Victoria, to establish its own evidence base has catalysed its transformation into an emerging research leader. We hope that today's presentations, which cover a diverse range of topics, will entertain, enlighten, and perhaps even surprise you. Some 22 years ago, Spectrum was launched by the Victorian Health Department under the management of Eastern Health. A tiny part of Spectrum's budget was allocated to research, primarily for the evaluation of Spectrum's flagship residential treatment program. This was invested in a single clinician researcher role to which Rosemary Thomas was appointed. Early publications, which are highlighted here along the timeline, don't try to read them, centred on the effectiveness of clinician training for attitudinal change, authored by Spectrum's first consultant psychiatrist, Dr. Ray Kravitz, in 2001 and 2004. Rosemary Thomas, working with Carol Hulbert from Melbourne University, evaluated Spectrum's residential treatment program. The first publication supporting the effectiveness of Spectrum's work was published in the Australian New Zealand Journal of Psychiatry in 2007. Clinician interest in topics relevant to borderline personality disorder drove several publications, including an article on family experience of borderline personality disorder in 2008. This was followed soon after by a clinical student-led project examining the effectiveness of treatment across subtypes of borderline personality disorder. Now, this was Spectrum's first student publication. Spectrum's work gained international prominence following publication in the prestigious Journal of Personality Disorders in 2010. This described the work of Carol Hulbert of Melbourne University and Rosemary Thomas, describing a model of predicting self-injury, a prominent clinical feature associated with BPD. Just two before. Sorry, we apologise for our technical difficulties. This same year, Spectrum published a definitive text on borderline personality disorder for Australian health professionals. This was co-authored by a senior psychiatry consultant and good friend and mentor to many at Spectrum, Associate Professor Josephine Beetson, as well as the current clinical director of Sathya Rowe and Spectrum's original director, Chris Watson. 2011 marked the first co-production with sister statewide service, Turning Point Drug and Alcohol Service in 2011 in the Australian Family Physician, exploring the complexities in the dual diagnosis of borderline personality disorder and substance use. In 2012, Spectrum published an evaluation of its first homegrown treatment program, an adaptation of acceptance and commitment therapy for the treatment of borderline personality disorder. This was followed soon after by the publication of the treatment manual, Wise Choices, and clinician training in the Wise Choices model was subsequently carried out across Victoria. 2013 saw the publication of an opinion piece led by Spectrum's then clinician researcher, Catherine Thompson, asking psychiatry registrars how their training program could better incorporate contemporary treatment content relevant to BPD. Now, to this point, I want you to bear in mind, Spectrum was primarily a clinical and training organisation with a small staff of around 35 people, 86% of whom were clinicians. Toward the end of 2013, Spectrum recognised its need to grow the research program to better communicate its often groundbreaking clinical work, as well as demonstrate that its treatment program was evidence-based and best practice. The decision was made to hire a non-clinical researcher to focus solely on research and evaluation. Appointing a dedicated research fellow to this role enabled Spectrum to take a more prominent to take a more prominent role in Spectrum's work. Since then, research has literally taken off. Since 2013, Spectrum's research program has grown and diversified, providing a platform for sharing Spectrum's knowledge and expertise internationally. What started as a service evaluation research program has expanded to include a stable of funded collaborative research. Spectrum is collaborating in a research capacity with a range of services and organisations, including the Coroner's Court of Victoria, the Austin Prevention and Recovery Care, Forensic Care, St George's Hospital at St Vincent's, and multiple Eastern health organisations, including the Peter James Centre, Emergency Department, and Mental Health Access. In addition to Turning Point, Ambulance Victoria, several of the state government branches, and the Eastern Health Foundation. Outcomes from some of these collaborative projects will be presented in this afternoon's program. So grant funding for specific projects, as well as large state-funded initiatives, total several $1 million to date, and Sathya articulated some of those in his presentation earlier. Spectrum's research accomplishments since 2013 include supervision of 11 high degree research students. This includes PhD, clinical masters, and Doctor of Psychology degrees, so far resulting in 4 publications, 4 manuscripts under review, and many at various stages of preparation, as tends to be the way with student papers. The inclusion of a scholarly research project within the psychiatry training program has provided an opportunity for Spectrum to supervise 9 registrar projects to date, with now 4 published. We had 1 accepted yesterday and more in the pipeline. So Spectrum may be getting a bit of positive press among trainees, actually, as we've had inquiries from non-Spectrum registrars seeking project supervision from us. Spectrum has also published 11 original research studies with an additional 4 under review, and 3 of those I've highlighted here. The coroner's study in psychiatric research, the intensive group program study, and the medications paper, each of which Sathya touched on briefly in his presentation. This same year, Spectrum published a definitive text on BPD for Australian health professionals. Oh, my apologies, I'm out of order. This is a rapidly changing field, and reviews reflect a consolidation of information together with new insights and innovations that shape the way we understand, diagnose and treat personality disorder. And you'll see that we've published 9 reviews, 2 of which are going to be presented in this afternoon's program. Treatment manuals, textbooks and chapters also shape professional education and clinical practice, and Spectrum is active in these as well, and a few are highlighted in this slide. Spectrum shares its research via national and international conference presentations. These include broad psychiatry organisations, as well as personality disorder specific congresses. This is also an excellent opportunity for us to learn from others, as well as develop and strengthen networks of like-minded researchers and clinicians. The implementation of recommendations arising from the Royal Commission into Victoria's mental health system will likely see Spectrum's growth and diversification continue well into the future. The vision for Spectrum research is outlined in our research strategy, which will be launched today. This is indeed an exciting time to be conducting research in the personality disorder field. The growing prominence of the consumer movement is invigorating debate and broadening recognition of the magnitude of the unaddressed need, the extent of human suffering when those needs aren't met, and the rewards when we promote human dignity and equality through understanding and acknowledging where we can and will do better. Research and advocacy are fundamental to these advances, and Spectrum's vision embodies this. Thank you.
So thank you, Gillian, for that very insightful and exciting look at the Spectrum research program. You managed it extremely well despite all the technical difficulties. Probably today in Victoria, we are just coming out of the lockdown and all the rules of lockdown have gone away, and which probably the technical difficulties probably reflect the fact that we all need to get back together and start meeting in person. Now, I think it's my pleasure to welcome Adjunct Clinical Associate Professor Alison Dwyer, the Executive Director of Research and Chief Medical Officer of Eastern Health. Alison has over 12 years of experience in medical services management roles at major tertiary health services and currently holds many positions, including Board Director of Peninsula Health and Chair of Medical Administrative Workforce Planning Group for the Royal Australasian College of Medical Administrators. Her research interests have focused on junior medical staff well-being, which is very important, engaging medical staff in quality, and the role of medical administrator in health services. So Professor Dwyer will speak to us about the Eastern Health and Spectrum Research Strategy and launch the Spectrum's research strategy. Over to you, Alison. Thank you.
Thank you very much. So thank you very much for the opportunity today to attend the Spectrum Research Forum. I'm very excited by this, and I'm incredibly proud of what the journey has been so far for the team, but also their journey and their path going forward. But before I start giving you a bit of an overview of our research strategy and the principles here at Eastern Health, and particularly how Spectrum is a core component of that, I do want to begin today by acknowledging also the traditional owners of the land upon which we meet today, and pay my respects to the elders past, present and emerging. And I extend that respect to Aboriginal and Torres Strait Islanders people who are here today. So Eastern Health is one of our second largest health services within Victoria in the east of Melbourne. Part of our strategic plan has research and innovation absolutely core and fundamental for what we do here at Eastern Health. We are on a journey to build a strong culture of innovation, and our reputation continues to grow within Victoria, nationally and internationally, and Spectrum as part of that. And it's through this continuous curiosity and commitment to continuous improvement that we are able to understand the importance of research and innovation to actually improve our clinical care. The principles of our Eastern Health research strategy do align with our overarching mission, which is about great care everywhere, every time. And looking at the strengths that we have at Eastern, it really is about, and again, the strengths that Spectrum brings, is that we are focused on translating that research evidence that we have back into our practice, but also learning from the best evidence that is out there and contributing to that evidence. Looking at the elements that we are trying to strengthen here at Eastern, and again, it's about the elements that Spectrum live and breathe for us every day, is looking at that. Our first priority area is looking at our organisational capability for high quality research. The second element is investing in research activities that really are strategically aligned to improve the health of our patients and our people. And then lastly, partnering for research that is strategically aligned. And really that partnership that I see within Spectrum, within our health service and more broadly is absolutely where we want to go from an Eastern Health perspective. So in regards to our principles, we have a number of research centres here at Eastern, and we've got certainly a very large clinical trials unit. We are growing our Turning Point service, and we also have a Centre for Patient Safety and Research and an Allied Health Centre. And across all of those, we have basic research, translational research, applied research and implementation science. Where the interface is for Spectrum is across all of these services, and that's what delights me the most when I see what the potential is and what the outcomes are that are coming out of Spectrum, is that it does have a number of touch points across our research institutes. There's an incredible amount of potential with that collaborative research that's occurring already, but also going forward with the research strategy that you'll see today. It really is strengthening that integration between Spectrum and our research centres at Eastern Health, which is very exciting for us. We do have an overarching research framework at Eastern that really looks at what are our strengths within the organisation, but what are also those national priorities that we want to contribute back to, both within Australia but internationally as well. And really the elements that are coming through within the NH and MRC priorities, with the Australian Research Council priorities as well, do align with the components that Spectrum wants to undertake, particularly around the personality disorders and integrating with the mental health and ED teams. We also know from the MRFF funding that's coming out soon as well, we know that that funding at various points is now targeted towards a lot more around our mental health strategies, and we do want to engage with that. So we're very excited about the potential that can occur from the work that is already occurring within Spectrum. Just so that you can see the broad framework of what we're looking at here at Eastern, we do have a number of elements across our research frame, both from a clinical trials perspective, a health services research perspective, and our knowledge translations perspective that we can see already Spectrum is engaged with but can grow with. One of the components that I particularly see Spectrum has a huge opportunity is around that patient experience and consumer experience, that lived experience from our consumers, but also focusing on vulnerable populations and advocating for vulnerable populations. And I can see that that's going to be an area of growth that we want to go down the path with Spectrum with. So just more broadly, not only do we have a framework, we have an extraordinary amount of output here at Eastern, and it's not just around our number of research applications that are occurring across the organisation, but also our research publications. So you can see over the last 10 years, we've had an extraordinary growth across the board around the research impact that we're able to provide here at Eastern, and Spectrum is absolutely part of that. And noting that the last 18 months, we've had this little thing called COVID that has been huge, but has certainly not deterred our clinicians and our researchers from undertaking extraordinary research here as well. The last slide that I did want to show you is that research output across the board at Eastern has grown. And if you have a look at the third last column, Spectrum is absolutely increasing its research output, but it's increasing its research impact. So as you could see from Gillian's slides earlier, the type of publications and the type of work that Spectrum is doing is nationally and internationally recognised, and is actually showing very clear outcomes from a personality disorder perspective. So we're very delighted with the direction and with the output that Spectrum has going forward. So probably my last comment to say is I'm very proud of what Sathya and Gillian and the team have been able to develop. I can very clearly see that the Spectrum research strategy is integrated into our Eastern Health research strategy going forward. And I'm super excited and I look forward to the next part of your journey around the next phase of Spectrum's research direction. So thank you, Satya.
So thank you, Alison, for that very interesting presentation, as well as for your ongoing support for Spectrum research activities. Now, I would like to introduce our first keynote speaker, Professor Bryn Grenier from Project AIR, for his presentation on the current challenges and opportunities in the treatment of personality disorders. Bryn Grenier actually doesn't need any introduction. He is a senior professor of psychology at the University of Wollongong and the director of Project AIR strategy for personality disorders in partnership with New South Wales Health. Over 2011 to 2021, he is listed in the world top 1%, in fact, top 0.21% of experts in the field of borderline personality disorder. So Bryn Grenier is an absolute expert when it comes to personality disorders. Bryn also is the president-elect of the International Society for Study of Personality Disorders, and he recently also he was the recipient of Order of Australian Medal. Bryn and his team have been awarded over 50 grants, totaling more than 18 million in funding, and he has published over 175 journal articles, chapters, books, and monograms. Bryn will be taking some questions after his presentation. So please submit any questions through question and answer function during his talk. I'll be collating the questions during the presentation, so please send them through as soon as possible, and don't please wait till the end. So before I hand over to Bryn, I would like to acknowledge that Bryn is a very important voice in the field of personality disorders, not only in New South Wales and Australia, but also across the globe. Over to you, Bryn.
Well, good morning. Thank you so much for inviting me to do this presentation. It's wonderful to be here presenting to Spectrum and to be part of this research forum today. I'd like to particularly thank Associate Professor Satya Rao, Clinical Director of Spectrum, and also Associate Professor Julianne Broadbear, the Head of Research and Innovation of Spectrum, for inviting me. Also, congratulations on the work that you've done over the last 20 years and the launch of the research strategy. So it's wonderful to see the progress that's being made by Spectrum and the innovation that's happening, both that we've heard about today already, but also into the future. I'd also like to just acknowledge that and pay my respects to the traditional owners of the land on which we meet. I myself, right now, am presenting on the land of the Wadi Wadi people of Dharawal country at the University of Wollongong. And I'd like to pay my respects for elders past, present, and emerging. I'd also like to acknowledge anyone here with lived experience of mental illness, and the voice of people with lived experience is essential to the development of our work and practice. So I'm really using this opportunity to really talk about current challenges and opportunities in the treatment of personality disorders. I'd like to start firstly by acknowledging the support of New South Wales Health, who's supported Project AIR for the last 10 years, and also the Illawarra Health and Medical Research Institute in the university. That's our home base there, but we spend a lot of time out in the field. Also, the large number of people who have worked for Project AIR. What I'm presenting today in many ways represents a lot of the work of these people who have contributed, and also in particular people with lived experience who have helped us to co-design many of the work that we've done and have been very, very helpful in terms of giving back to us some of their experience and views. Just a quick shout out. We are very excited that in 2 years, the International Society for the Study of Personality Disorders is actually hosting its Congress in Australia. So please save that date in November in Sydney. It's going to be a wonderful opportunity for all of us to consolidate. Project AIR is not having a conference that year. We're just going to put all of our energy into ISPPD, and I'm hoping that Spectrum will also jump on board and we'll all meet at the same place in November in 2 years' time. So here are some of the challenges, and I'm just going to briefly overview them and get into detail. I've just chosen 3 challenges. The first challenge is that although research is growing and we have access to and have demonstrated efficacy of treatments, but accessing care can be challenging, and we really need to think about that. Secondly, that stigma and quality services are still a challenge, and we need to think about how we can make services much more friendly and appropriate for people who are seeking help. And thirdly, although we know a lot about borderline disorders, we don't know so much about a lot of the other personality challenges. And I wanted to focus and finish by talking about what opportunities we might have there in an example. So the first challenge, access to care is a challenge. We do need stepped care approaches and understanding the mechanisms. The good news, of course, is that psychological therapies do work, and many psychotherapies designed specifically for borderline personality disorder are now available, including mentalization-based therapy and dialectical behavior therapy. We know that most of these treatments do help in decreasing symptoms. We know that people can recover and do recover from BPD, and that mostly psychotherapy is helpful. We also know that short-term therapies can be very helpful as well as long-term therapies. And there's a lot of interest at the moment in the duration and how long you need and the timeliness. And I'll talk a little bit about that too. This is just an example of the growth in science. So in 2017, there was a major meta-analytic review of 33 randomized controlled trials. Just 4 years later, it was suddenly 75 randomized controlled trials. So a double of evidence in the last 4 years. So it's a hot topic, personality disorders. This is one of the early reviews. And then this is the most recent, the Cochrane review. And it basically shows that there are over 16 different types of psychotherapy. Treatment duration in those randomized controls range from 1 to 36 months. But we don't have any magic bullets here. We know that basically the common factors seem to be helping to improve clinical outcomes, and there's no specific treatment from any specific brand name that seems to be responsible for the kinds of changes, nor do we know exactly what is the right duration. We know that personality disorders are very prevalent in the community, and the best estimates are around 6 to 7.8% in the population. We know that people with personality disorders present to hospitals in great numbers. This is the study we did of a 3-year catchment of everyone living in an entire area that was representative of the Australian population. And in 36 months, in a catchment of 270,000, which is about typical for the kind of population supporting one major or a couple of major hospitals, about 1% of the population were seeking hospital care, with an average of 2.25 admissions per patient, with a range of 1 to 36. And these are the major diagnoses that show up both in inpatient and emergency department. So you can see here, although the highest numbers are for people with psychosis and affective disorders, personality disorders are the 3rd largest group, and by far the triad in some ways. These ones down here are quite small, and self-harm, interestingly, if you added that and put it here, it would probably come up. So it's possible that these self-harmers are possibly part of the personality spectrum as well, but have not yet been diagnosed. Also, the burden is not only in terms of showing up to inpatient or emergency departments, but actually representing. So we talk about 28 days of discharge, the risk of representation of being a particularly important metric. And you can see that basically personality disorders and psychotic disorders have the highest risk of representation. But do we have enough therapists? So we're talking about a large group of patients. They're already in our hospitals. We're already seeing them on a daily basis. And do we have enough skills? Now, when Spectrum was first set up 20 years ago, it was supposed to be like the specialist service to deal with these particular patients. And it was quickly swamped. Because clearly the population prevalence is very, very large, and that every health service and every health clinician has to do something to help work with people with personality disorders, and it can't be hived off into some kind of like special boutique service. This is a really good study that came out of a couple of years ago in psychiatric services, asking, do we have enough clinicians to meet public need? And the data is quite sobering. The good news is that Australia is the top of the pile. So we have the best ratios in terms of clinicians to patients seeking care. But we still don't have enough. So if you have a look here, and I think this is the critical one, that the ratio of people who have sort of specialized DBT skills or certified providers in terms of like have special certificates in DBT or mentalization-based therapy, we're way under. We don't have the number of people seeking treatment is 2,878 patients per every single one of those evidence-based therapists. So it's never going to match the demand, and that we have to all play a role, and all mental health practitioners really have to, and the estimates here say that every health practitioner needs to spend about 4 hours a week seeing patients with personality disorders in order to meet the demand. So that's it's a really important kind of figure to keep in mind. Stepped care, of course, is one way of trying to do more with less, to try and say, okay, we've got a limited psychotherapy resource. How can we make sure that we use it wisely? There's been a number of attempts to discuss the idea of stepped care and psychological therapies way back in 2005. Approaching stepped care by in personality disorders was already being discussed, 5 or 10 years ago. We certainly, when we started Project Dare 10 years ago, realized based on the population prevalence, we were never going to be able to survive by setting up just a specialized service. We had to do something that was going to be whole of service. So that was where our stepped care gold card clinics came about. So the idea was, we've got this great big group of clients showing up in emergency and inpatient units. We need to move them into evidence-based therapy as quickly as possible, and away from these most expensive therapies and into therapies that are actually more likely to be efficacious. And the gold card clinic was to take people from that acute crisis situation, sit them down and start the process of psychological therapy as quickly as possible. So we gave people a gold card when they showed up at emergency or they were being discharged from an inpatient unit. And within 1 to 3 days, they were sitting down, having an appointment and starting the process of talking about their issues. Our gold card clinic is only 1 month, so it's a 4-session intervention, but it really does set people up for care in the community and keeps them from going back into hospital, and it gives them a service when they're asking for it. So striking while the iron's hot. We evaluated that in a cluster randomized controlled trial. So essentially we had 2 hospitals, almost identical, separated by a geographical boundary, a national park. And we observed them for 18 months. So we just looked at to see what was happening in terms of the patients flowing through. And then after 18 months, we randomly selected one of those 2 to implement the Gold Card stepped care model, and the other stayed as treatment as usual. So we ended up with 338 patients in the stepped care program and 315 in the treatment as usual program. And what we found was just setting up those Gold Card clinics had a massive impact on reducing the burden in the emergency department and in the inpatient unit. So we immediately started to have shorter bed stays because there was a clinic to send people to that was persona disorder specific. Instead of staying in hospital for 2 weeks, they were being discharged within 4 days. Having the Gold Card clinic meant that people were actually getting a service, and they were 1.3 times less likely then to represent in crisis to emergency department. And just from doing that, the cost savings were really considerable, about $4,000 per patient per year from implementing that. We then asked ourselves, well, what's happening in this 1 month of therapy? Is it actually useful, and are good things happening? Interestingly, what we found was that half the people who went into the Gold Card clinic, that was enough. So they got the service that they needed, their crisis was attended to, and then they went back to the community. Half of them, though, did step down to psychological care or psychiatry care or GP care or other kind of care in the community. And only 13% were retained by the publicly funded mental health service. And they typically were the ones that should have got case management and DBT or some other program, but weren't able to be sustained in the community through other services. So in many ways, the Gold Card clinic also triaged patients into those. Interestingly, also, the people actually improved. So the 1 month was actually helpful. Their BPD severity reduced, their quality of life improved, and the largest reduction was actually for suicidal ideation, an effect size of over 1. And so in many ways, the Gold Card clinic is like a suicide prevention pathway for severe clients. Unfortunately, there's a big problem though, and that is once they go into the community, only at the moment, half the people who are getting into psychological therapies and really working on their problems are improving. So we looked across, and this is a review that we've just published in Australian New Zealand Journal of Psychiatry, of the 28 good controlled studies that we looked at, with about 2,436 participants being treated for 11 months. Only 50% of patients responded. In other words, reliably changed or met threshold for recovery. And this is a problem plaguing people across the world, is that not all of our treatments are working. This is another paper we've just put out trying to understand this a little bit more. This is on data from our own sample through Project AIR in our longitudinal study. So looking at what's happening after 12 months. And really there's some significant interpersonal attachment-based and impulsivity, emptiness, and other kinds of problems that people are struggling with that seem to make treatment difficult. So I think there's a place for stepped care, but there's also a place for us to just improve treatments and really try and understand what it is that we actually need to be doing for those, particularly that are not responding to the treatments that we currently have available. Second challenge is really around stigma. I mean, it has to be said that personality disorders are still highly stigmatized. That when I look at the, big reports, like the recent Commonwealth government report on mental health and suicide prevention, the Senate report and so forth, they're really sort of personality disorders, despite being just like in the top three, you know, psychosis, depression, personality disorders. You see so much more written about the first two, which interestingly have some drug therapies that can be helpful. Personality disorders, which is reliant upon psychological therapies, is a real kind of challenging part of psychiatry at the moment. And that's why it's great for you all to be here today. So in many ways, what are people saying about what the problem is? So in terms of that, we listen to lived experience. We ask consumers and carers and some clinicians, what are the priorities and what are the issues? And there's really four. Firstly, they're feeling really left out of treatment. So there's all these experts telling them what to do, but they're not feeling like they have any voice. So we do need to listen more to lived experience, and we do need to have more carer involvement, and we need to develop peers with lived experience to be working alongside us. I think we do need to do more around addressing stigma. Clearly, we need to do more in terms of having stepped care approaches and removing barriers to treatment so that when people show up and say, I'm in crisis, they actually sit down and start talking about their issues. And we need to support clinicians by giving them better training and better models of care. We've done quite a few studies, and this is just a sample of them, on listening to people with lived experience. Particularly interesting when you ask them about, well, what helps you in your recovery? And this is what they tell us, that actually a lot of people with personality disorders are really stuck for a long time because they don't really know what's going on for them. And it's only when they're properly diagnosed that suddenly they go on the recovery journey and they can really improve. So recovery is kind of like a really important touchstone in people's understanding and of the disorder and what they need to do to improve. But unfortunately, diagnosis is not done well, and that's part of the sort of issue where stigma, I think, plays itself out about should we even diagnose people with personality disorder, and there's all this kind of like challenges around that. Most people that we talk to who have been diagnosed are really happy that they got diagnosed because they understand the issue and they understand that it's treatable and they know what to do. And then they can go on the recovery journey and really work on that. This is one of my favorite articles. It was published a couple of years ago in Personality and Mental Health by Leicester and Group from the UK in Lancaster. Service users' experience of receiving a diagnosis. And it basically says that, you know, if you deliver the diagnosis poorly, it elicits powerful negative emotions in service users and reinforces their perceptions of being stigmatized, rejected. But if it's delivered well, you know, it's explained to them, it's compassionate, that really helps to connect their internal experience with the diagnosis and the problems, and then discussion of treatment and options is explained. They really feel more hopeful. They feel like they can get on the recovery journey. They feel like they trust health practitioners much more. They're really positive about that. And it really helps them. And it's a powerful touch point in their treatment. So I think one of the things that we really need to focus on in terms of challenges and opportunities is really doing the whole diagnosis thing much better. We also need to use peers with lived experience, because in many ways, you know, because of the broken trust with health services, people who have lived experience have powerful messages around hopefulness that they can give to people that we as clinicians can't necessarily give. And we certainly find that using peers, and we're starting to use them now, and we're running some research studies with peers with lived experience in various groups and programs. It really does change and help people who are in the early stages to become more focused on the idea of recovery and really helps them, I think, to provide much better and more powerful messages. Okay, the final challenge I'd like to discuss today is we do know a lot about borderline disorders, and there's a lot of research and there papers, you know, the representation is about 80% of the papers in the field are on BPD and 20% are on the other disorders. We really do need to deepen our knowledge and work into other problems. So I'm just going to give you one example, and that's pathological narcissism. But I think it's important to see this in the backdrop of what's going on with diagnosis. And this is one of my favorite papers. This is from Carla Sharp in Texas at the University of Houston. It's a beautiful study where she did a factor analysis of all of the BPD and all of the other personality disorders, because you know at the moment in the DSM-5, there are 10 personality disorders and there's a 250 or 280 items which you can go through all of those. When you do a factor analysis of all of those items, there's a general factor. So there's an underlying personality pathology, but there's also some specific factors too. And I think this has been very influential in the field. The general factors are these in bold up here: identity disturbance, affective instability, emptiness, self-harming, interpersonal irritability, suicidal, abandonment, anxiety, intense anger, and transient dissociation. In many ways, those general factors are actually borderline personality disorder. So borderline personality disorder is kind of like the underlying general disorder, of which there can be lots of different subtypes. And this is, so we're thinking about the ICD saying that fundamentally the self and interpersonal disorder is the problem that we're trying to treat, fundamentally underlying personality disorder. And then we have these types of trays, is the person more negative affectivity in terms of intense emotional experiences, or are they more detached? Are they challenging in terms of antagonism, so more narcissistic and callous? Are they very disinhibited and very impulsive? Or are they really kind of like suspicious and maybe a little bit odd and eccentric? These kinds of traits vary, and they vary between patients. So we probably should be thinking more about these and focusing on these than just, does the person have BPD or not? So this has just come out a couple of days ago, and it's just one example from our lab of how we're trying to think about, well, what else apart from BPD and how is it important? So pathological narcissism is more around that kind of antagonism, challenging interpersonal features, self-importance, perhaps callousness. And if you look at the impact of pathological narcissism on the community, it's really considerable, particularly in close interpersonal relationships. So we asked people who are in relationships with people with pathological narcissism to describe the issues. And we had over 1,000 people respond to us. It's a big issue in the community. And the findings are disturbing. That living with somebody with pathological narcissism, people said that they felt like the relationship felt abusive, that there was financial burdens imposed upon them, there was unwanted sexual behaviors, and really it kind of started to sound like, coercive control and almost like domestic violence or worse. And although health services sit here and we may well be doing therapy with the victims, we also need to think about, well, people with narcissism are being referred by their partners and they are sitting in mental health facilities. But do we have good models of care to understand both how to work with people with pathological narcissism, but also how to work with people who are so-called victims or over involved in ways that are really destructive with this group. So it's a kind of another whole new area. All right, so I've probably given you enough challenges right now. I do think we have an opportunity to develop stepped care approaches, and I know that there's some work happening in Victoria around that. We do have a massive opportunity if we listen to the people with lived experience tell us what's important. And I gave you an example of that we really need to improve how we talk to them about their diagnosis. And we also need to deepen knowledge and work in other disorders. So they're just 3 that I wanted to choose today, and I'm really happy to open that up for discussion. Thank you.
Thank you very much, Bryn, for that very insightful presentation and for highlighting all the challenges and the opportunities that we potentially have. Now, I particularly like your Gold Card Clinic presentation. I've heard you speak about it many times, and we are doing some research in emergency department presentations, and I would love to work with you to see how we can, get the Gold Card clinics and adapt it to Victorian hospital conditions. Thank you. We got a few questions. We have some time. The first question is, I think you did address this in your presentation, Bryn. Evert Wadi, as one of the senior clinical psychologists in Victoria, has asked this question, asking you to highlight the impact and the issues arising from the shift to the dimensional model of personality disorders in ICD-11.
Yeah, look, and thank you so much. And it's so wonderful to be here among so many friends. I've had a little look at the attendees, and it's so nice to see so many colleagues who've jumped on to be part of today. Look, it's a good question, Yvette, and thank you for asking it. I just have to start by saying the ICD-11 is really for the whole world. So even though we're sitting here in Australia in what we could be considered to be an extremely well-funded and sophisticated health service, the ICD has to function in every country, and countries that maybe are really struggling, I know that there's a couple of countries that have like 2 psychiatrists in the entire country, for example. And so the ICD is very minded around the idea of funding, that the ICD should actually support funding decisions. And I think the thinking around that there's a single disorder of personality, which it's come up with, really means, severe, moderate, or mild. That really has implications for how you fund. So if it's a severe personality disorder, then there should be a specifically funded package of care that goes along with that. And I think then the clinicians can then work out the issue around trays and the specific kind of factors that are important for that individual. And I think in many ways, probably the old 10 personality disorders is unwieldy and a distraction for busy mental health services that need to kind of like get on and actually fund and get patients treated. So it's kind of got that kind of philosophy behind it. As researchers, though, we very much see, of course, things like narcissism and pathological narcissism are actually really clinically important. And there's still plenty of scope for us to still be using and thinking about things along those lines.
Thanks, Bryn. Bryn, I have a question. Would you comment on the complex PTSD, introduction of complex PTSD into ICD-11? And how that might impact on the diagnostic practices, especially in the Australian context, where clinicians often tend to, even before we have actually had the official launch of ICD-11, clinicians tend to give a diagnosis of complex trauma disorder, complex PTSD, instead of personality disorder, which further stigmatizes people with personality disorders in the long run. Would really appreciate your comment on this. We have had a lot of debate in Victoria regarding this.
Well, it's good to have both, because there are certainly patients who have complex trauma. Not all of them have personality disorder. And certainly there are people with personality disorder who don't have trauma. And we have quite a few that we've talked to who said, nothing happened to me, but I just have a lot of trouble managing my emotions, and I become So look, you kind of need both. Some people will have both disorders and some people will have one or the other. I think it does matter in terms of choice of treatment. Complex PTSD does require you to focus on exposure to the trauma and the trauma memories and the kind of the complicated things that happened that were behind that complex trauma. And the issue of safety is so critical that in many ways, the underlying philosophy around personality disorder therapy, which is about building a stronger sense of self and a stronger sense of who the person is and a stronger sense of others, that kind of needs to happen first. And so complex PTSD treatments, before you even get to treat the trauma, you have to spend a lot of time on safety. And so there's a lot of parallels there, I think, with personality disorder therapy. There is some interesting research being done in Germany, and Martin Bohas's team just presented some results saying, you know, the fundamental thing with people with complex PTSD is to make sure you really focus on the trauma, because that is really, in some ways, causing a lot of the other emotional dysregulation problems. So you can't avoid using the exposure therapy to the trauma. But, you know, for people with personality disorder without trauma, of course, that's not going to be relevant or useful. So we kind of need to have both. And I think the field is increasingly kind of like thinking about how these things work and different types of individualized care for different patients, depending on their need.
Thanks, Bryn. If you don't mind taking a few more questions. There is one question from a carer. I'll just read out the question. Is there an efficacy in residential treatment? And if so, can they have a lasting impact? My daughter is an 18-year-old struggling, and so are we. We have tried DBT and it did not work.
Well, look, firstly, let me just express my compassion towards the person that asked that question or the family that asked that question. We are very interested, and I think in my presentation, you will have seen that this is actually a big challenge in the field, that at the moment, our treatments are only working for about half the people. So, you know, the glass is half full or half empty. The good news is that for half the people, they get onto the recovery journey. For those who are struggling and are not improving and are finding treatment a challenge, my advice would be try a different therapist. You know, just keep going with and get your daughter to meet as many different people as possible until one of them kind of clicks, because it's really only the therapeutic alliance and the real sense of trust that can take a while. And, you know, you might need 6 months or 9 months or 12 months before that sort of sense of safety and trust develops. And that's probably the best advice I have. Although it sounds really attractive, the idea of just, if I put my daughter into this place, magical place that has, you know, this residential care, that somehow it's all going to work. The research doesn't suggest that's the case. In fact, residential care can actually sometimes make people worse. And some of the work that we do in Project Dare is actually dealing with people who have been in hospital or residential situations for too long, and they actually become worse and worse and more aggressive and more suicidal and more challenged. And I'm sure Sathya has seen that multiple times before too. So residential care, sadly, is not the solution, but a good relationship with a trusted therapist is the best hope that I can recommend for your daughter, and wish you all the best with it.
Thank you, Bryn. I might just add saying that if this is in the Victorian context, these are precisely the people we would want to be working closely with, especially if they've had treatment attempts in the community and it has not worked. So I would encourage you to call us at Spectrum if your daughter is living in Victoria. As well as just add to what Bryn was saying, we did have a residential program in the past. What we found was that people did improve, and we used to admit them for 1 to 2 years, and people would improve, but after a discharge, again the symptoms would revert back. So that's why we changed the model of care to a community care. But we might look at using residential facility for crisis management in the future. Maybe one more question, Brent. This is, there's a question by Barbara Mullen, a care advocate. I think you have already answered that question, so I'm going to skip that. There's another question saying that I have a question relating to limited efficacy of therapy. Did the study include private and public services? Did you identify systemic factors that interfere with the progress? And was there a difference between public and private? Asks one of our senior clinicians in Alfred Hospital.
Hi, Birgit. Nice to see you online. Thanks for the question. No, I think there's really no difference between public and private from what I can tell. And certainly our experience, the issue seems to be in terms of non-response is about these really key issues around interpersonal trust and the capacity of somebody to develop enough attachment to a trusting person to be vulnerable enough to look at their problems. And you know, when you're feeling really empty inside, and you know, Yvette Vardy and I did a study on intolerance of aloneness. We've done some other studies on emptiness. These are very challenging experiences for people to have. And it's so easy to try and push them away with impulsive behavior or problematic interpersonal relationships. But to get in touch with that and to be able to trust yourself with a therapist to do that, it's really therapist-patient alliance factors that seem to be the critical thing, not the source of funding, whether it's public or private. It's the quality of the clinician and the match with the patient.
So thank you very much, Bryn, and I really appreciate you taking the time to attend our event today. I know what a busy man you are. There are a few more questions. Unfortunately, we are run out of time. We are cutting into a coffee break. I've already taken about 1.5 minutes of your coffee break. So I might close the session this morning and request all of you to come back at 11:30. So thank you very much, Bryn, for your presentation. That was very, very interesting and very insightful. Thank you. Have a nice day.
Thank you.
It's now time to introduce our next keynote speaker, Professor Suresh Sundram, to present the multifaceted nature of trauma for refugees and asylum seekers. Professor Sundram holds many esteemed positions in and around Victoria and from his CV around the world. He is the current head of Department of Psychiatry, School of Clinical Sciences, Faculty of Medicine, Nursing and Health Sciences, Monash University, as well as the Director of Research Mental Health Program at Monash Health. He is an expert consultant on asylum seeker and refugee mental health to the UNHCR. And he has provided similar expert advice to the United Nations Commission on Human Rights. He has also provided expert advice to the Australian Human Rights Commission, Australian Department of Home Affairs, United States State Department, the governments of Papua New Guinea, Republic of Nauru, and Sri Lanka, as well as numerous non-governmental organizations. So over to you, Suresh, and thank you very much for participating in our forum.
Thank you, Satya. And thank you for the kind invitation to present it. Really a very important event in Spectrum's history. I'm going to talk about a different aspect of the impacts of trauma from what you've heard to date in the session this morning. I want to talk about the impacts of the quality of the trauma and how it influences both adult functioning as well as child functioning. Most of my data and the studies that have been done to date are focused on the adult, and so I'll spend most of my time talking about that. But I think we've reached an unfortunate position in our history in Australia such that we now also need to consider the impacts of these types of traumas on children. Get control of the screen. Yeah, great. Thank you. Can I get control of the slides, or is that something that is not going to be possible? Anyway, these are my disclosures. None of these are relevant in terms of the content of what I'm going to talk about, although many of these agencies have supported my work. Thank you. Next slide, please. The talk that I'm going to give you I'll give you a little outline of the current situation in the Australian context. That's really just to give you an idea of the numbers and the different subclasses of people that are caught under the system that we have in Australia, or that we have in Australia. I want to talk a little bit about how these various traumas that people experience impact upon their mental health, and the outcome will be able to impact on mental health. And then I want to talk about the trajectory of that, as well as then the consequences of what's going to happen. Hold on. I am clicking, but I can't seem to get control. Anyway, so the Australian context, someone's able to move to the next one, next point. Yeah. In fact, if you bring up all the points on this slide, that would be fine. So the situation is that Australia has an excellent ability to look after refugees when they come to Australia as refugees. We have a generous refugee policy in terms of the per capita. In fact, we're ranked in the top 3 or 4 countries globally. Generally speaking, we take somewhere in the order of about 18.5 refugees. That number's increased in recent years, but we've obviously not been able to accept those people because we've not been, because of the situation with regards to COVID. In addition to that, there are a large number of people who live in the Australian community who are unauthorised. These numbers somewhere in the order of about 30 to 40,000 people who fall under the category of what we might term boat people, and I'll explain that in a moment. But in addition to that, there's somewhere in the order of about 60,000 additional unauthorised people in Australia. These are undocumented migrants. Many of these are visa overstayers. They constitute a significant portion of people within the Australian community, estimated by the Refugee Council of Australia to total about 90 to 100,000. And obviously these numbers are not able to be accurately fixed, but the estimate is of that order. Of the 30 to 40,000 maritime arrivals, what we have in Australia are people who have arrived without a valid visa. So these are people who've arrived by boat, generally speaking, and they've generally come from Indonesia or occasionally Malaysia. These are the people who are subjected to indefinite mandatory detention and that indefinite mandatory detention can persist for many, many years. Currently in Australia, there are very few people in immigration detention. The majority of those in immigration detention are people who've either committed a criminal offence in Australia and are awaiting deportation, or people who have been apprehended under other breaches or violations of the Migration Act and are being held in detention. There are few asylum seekers. There still are some, and there are, in fact, a very, I guess, noteworthy set of people who are still being kept in hotel detention, who have come from Manus Island and Papua New Guinea as well as Nauru. But generally speaking, these numbers are relatively small at the moment in current detention. However, of the 30 to 40,000 people, there is a subclass which are termed the transitory persons. These were people who were transferred offshore after having arrived on in Australian territory to one or two offshore regional processing centres. One of these centres was Nauru, the other centre was Manus Island in Papua New Guinea. The Papua New Guinea offshore centre has been closed, and those people are now awaiting transfer to somewhere else. That situation is unclear. At the moment, altogether in both Papua New Guinea and Nauru, there's only about 230, with most of the remaining 4,000 odd people being in Australia. There are about 1,000 people who've gone to the US, and the remainder are here. The quality of both the unauthorised maritime arrivals as well as the transitory persons is that the unauthorised maritime arrivals, that is those who came by boat but were not transferred offshore, will only receive temporary protection. That is, they can't settle in Australia, they can only receive temporary protection. The transitory persons, these are the people who were transferred to PNG or to Nauru, have been, according to current Australian government policy, not able ever to reside in Australia, and that's why they've been given the name transitory. It's very important in terms of what will happen to them and in terms of their psychopathology. Next slide, please. So when we think of the health of refugees and asylum seekers, I think of it really in relationship to 5 factors. The first is the pre-migration trauma, that the reason that the person or the persons or the families were initially fleeing their country of origin or their country of residence. This is the stress that's caused them to leave, and I'll come and describe those in detail in a moment. In addition to that, it's very important to consider what their pre-migration health status is or was. With regards to asylum seekers who have arrived in Australia, this generally can be assumed to be good. And the reason I say that is because it's very difficult for people who are in ill health to be able to survive the rigours of a journey to Australia by boat. In contrast, however, refugees who have been given a visa to enter or to settle in Australia can have a wide range of health conditions, but very important to consider. The third point is this migration journey or the transit experience. The migration journey can be as simple as getting on an aeroplane and landing in Tullamarine or Kingsford Smith Airport, or it can be the hazardous sort of journeys that we've seen all too often in the news, with boats sinking in the Indian Ocean as people try to transit from Indonesia to Australia, or the horrific conditions in multiple intermediate transit countries. The post-migration environment I'm going to spend quite a bit of time describing to you, and that's obviously the condition that people find themselves in when they arrive in Australia, and this is a major influence on their ability to deal with the traumas that they've experienced previously as well as current traumas. And then, of course, something which we tend to ignore. But of course, the ability to manage the sorts of stresses that I've just described will be mediated by a person's personal and social resources and their resilience. And this is very important to bear in mind. And there's clearly a factor associated both with regards to their current level of mental health, but also their subsequent level of functioning within the Australian community. Thank you. So pre-migration and migration trauma. Now, a lot of the points on this slide will be self-evident, but let me start with something that may be less self-evident, and that's the agony of choice. What I mean by that is that it is an active decision for people to leave their country or their region that they have grown up in or lived for most of their life. They've had to do it potentially leaving behind family members, leaving behind their community, leaving behind their colleagues and allies, leaving behind the community that they may have been struggling against an oppressor for a very long time. This tragedy of the agony of choice, in fact, has been highlighted very recently by the very urgent transition of people from Afghanistan, where in fact many families, parents have had to leave children behind, children have had to leave parents behind. And that's been, of course, extraordinarily difficult and traumatic for people. Then there are obviously things which are self-evident, things such as conflict, war, the sort of problems that cause people to leave in the first place. Individuals can experience torture, rape as both a form of oppression as well as a form of torture. Both of those are relatively uncommon. I tend to see, if you like, the worst of the worst cases, and even in the people that I see, torture is a relatively uncommon experience, although rape is an unfortunately increasingly common experience. I see, however, everybody having had some sort of traumatic loss, be that the loss of their community, the loss of their home, the loss of family members. The experience of forcible displacement is traumatic in itself, and people might well have to spend time in refugee camps. People might well be exposed to very significant adversity in the transit from their country of origin into a transit country prior to moving to a host community such as Australia. They may be unable to access proper food. They may well be exposed to high levels of communicable disease, may be exposed to violence within refugee camps. Of course, children will be disrupted with regards to their education as well as their health status. And then I have mentioned about the dangerous journey. So here, of course, people trying to move from Indonesia as a transit where they're unable to resettle to a country where they believe they might be offered asylum, such as Australia, having to suffer the experience of a boat journey in unsuitable watercraft, and obviously with the loss of significant amounts of or numbers of lives. Post-migration trauma is very important, and this is going to be dependent upon whether or not people are asylum seekers or refugees when they arrive. The first point of the refugee determination process, of course, is that anybody who arrives in Australia is entitled by Australian government policy to apply for asylum to be a refugee. So here, people who will undertake a refugee determination process by making an application to the Department of Immigration or Home Affairs. Of course, people who've already been deemed to be a refugee by Australia and been offered a resettlement place don't have to submit themselves to the refugee determination process here. And of course, that's a very significant step for asylum seekers. As I've mentioned, anybody who arrives in Australia in an unauthorised fashion is subject to indefinite mandatory immigration detention. This is a very considerable stressor, which I will spend some time describing. There is, however, also the potential of how the person is received by the broader Australian community. I've got here some examples of media profiling of refugees and asylum seekers as scapegoats for a whole host of other types of problems that the community faces. And of course, we see this very often, both in Australia, but also overseas, about how asylum seekers and refugees can be used as a scapegoat, both politically as well as socially. Next slide, please. So what I want to first, before I go specifically to the issue of refugees and asylum seekers, I want to place this within the broader context of migration, because of course, what we're talking about with refugees and asylum seekers is a variant of a migration process. Australia is a country of immigrants, right from the very time of the first European colonisation. It's really only the Indigenous members of the Australian community who aren't immigrants. And of course, the process of migration is a stress. However, we can think of migration stress as being on a continuum where there may well be low levels of post-migration stress, right through to people with very high levels of post-migration stress. And I've listed some of the groups that might fall into that continuum. There are two significant factors which influence migration stress. One of them is the level of acculturation, and the other is the security of a migrant's status within their host country. Acculturation, of course, refers to the level of familiarity that an individual has with the host community culture, and of course can be very high. If one goes to an Anglophone country as a migrant, then it obviously will be much easier for somebody from Australia to acculturate to Canada or the US or the UK than it would be if an Australian went to a non-English speaking European country, and that would still be easier than if one went to a non-English speaking developing country where one had little or no connection. So therefore, the reverse is true. People who have little or no familiarity with Australian culture will experience a high level of acculturative stress, and that may well then contribute to a high level of post-migration stress. In addition to that, the security of the status of the individual within the community is critical. If you've got a visa, you're allowed to resettle. If you're a refugee and you're offered a whole range of support, such as English language classes, a caseworker, etc., then that is going to ameliorate the level of migration stress. On the other hand, if you're not allowed to work, if your visa status is insecure and you're facing imminent refoulement or deportation, then clearly your level of post-migration stress is going to be great. Next slide, please. What we see in asylum seekers, I've described really as part of a continuum. So bearing in mind the stresses that I've just described on the previous slide, what we see in asylum seekers is really a four-phased transition. Now, initially when people arrive, they're generally speaking very pleased to arrive in a safe, secure country that they believe will now be the answer to the problems of insecurity and threat that they face. And so they go through a honeymoon phase where there's a general sense of relief and an ability to be able to feel safe and secure. However, as an asylum seeker without a secure visa status, and where in fact your acculturative stress might be very high, you begin to have questions. You start to wonder whether or not you'll be allowed to stay. You wonder or not whether you'll be able to integrate into the community. You wonder about the safety and security of the family members and community that you've left behind. And so there's a transitional phase, which is a high period of stress and a period in which many people transition away from the honeymoon into a level of doubt and worry. For a proportion of those people, if those stresses persist, we start to begin to see a range of psychiatric disorders. And I'm going to spend a little bit of time talking about the psychological factors underpinning those psychiatric disorders, in particular post-traumatic stress disorder, but also major depressive disorder. And then if that set of factors is allowed to persist further without treatment or with an increase in the severity of the stresses, we begin to see some of the rarer types of psychiatric disorders. We start to see the fragmentation of reality, the emergence of psychotic and paranoid persecutory symptoms, and the breakdown of families and family units. Next slide, please. So I've mentioned, actually, we might go through this point by point. If you could just, sorry, go back to the first point. Yeah, thank you. So the first point that I've mentioned is about this protracted indefinite uncertainty. So people are not clear whether or not they're allowed to stay in Australia. And in fact, the Australian government policy is that they're not going to be permitted. And so they have this terrible fear that they're going to be refouled to their country of origin, to be subjected again to the persecution that they experienced, which first forced them to flee. Next point, please. There is also, for people who've had an experience of immigration detention, as I said, all unauthorised arrivals will be subjected to indefinite mandatory detention. There is the fear of being returned to locked detention. Next point, please. There is, for those individuals, no prospect of family reunification. These people on their temporary visas or no visa status are not allowed to bring their family members to Australia. And so we have the terrible situation of children who've never seen their father, families where spouses are separated, and other sort of tragic outcomes. Next point, please. Many of these people are not allowed to work, or if they are allowed to work, their visa status really precludes any employer from taking them seriously. So they might be on 3 monthly visas, for example. Many of them have lost the ability to use the skills that they were trained in, and so they're not really able to do the type of work that they're trained to do. Next point. Unfortunately, both young kids who finished school and adults are not able to engage in any vocational training or tertiary education. Next point. And they're not allowed access to English language classes. So they're not, in a sense, able to acquire the sorts of skills which will facilitate acculturation within the Australian community, which obviously then contributes to high levels of stress. And then many of these people are still in community detention, which is a form of detention in the sense that people have curfews, they're prescribed as to where they're allowed to live, and they are not permitted freedom of movement, even though they might be living within the community. Next slide, please. So this is some data that we collected a few years ago. Debbie Hocking, postdoc, when she was doing her PhD or doctorate with me. This is looking at psychiatric symptoms in asylum seekers living in the community who've had no experience of immigration detention and who did not present with psychiatric disorders or psychiatric symptoms. They didn't complain of anything psychiatric or psychological, but we surveyed them for their level of psychiatric morbidity. The top row refers to those who've been granted asylum, so these are permanent residents, rates of depression of about 30%, rates of PTSD of about 27%. However, those on insecure visa status had about double the rates. Asylum seekers, 60% depression, post-traumatic stress disorder, about 50%. Okay. Next slide, please. Now, I want you to compare this with really the only study that will ever be published from the Manus Island Regional Processing Centre. The United Nations High Commissioner for Refugees asked me to do a survey of the mental health of these people, and the results were so extraordinary. They read the contents of my report into Hansard at a Senate Estimates Committee, and then subsequently we were able to publish it in a Lancet commentary. And the reason that they were so astonished the rates of psychiatric disorder. This isn't 20%, so we were able to survey 20% of all the detainees in Manus Island. post-traumatic stress disorder, 79%, a depressive or anxiety disorder, 88%, either one or both of these disorders, 93% of the surveyed population. These people have been in detention for about 3 to 4 years. Next slide, please. Now, these are data, again, from people in detention, but this is from publicly available data that Rowan Borschman from Melbourne University and his colleagues were able to extract from the public record. Self-harm rates of about 200 times that of the mainstream population. About 26% of asylum seekers in Nauru had self-harmed. We've heard about a number of the suicides, including some of the very tragic and horrific self-immolations. The photograph on the right is a child who was transferred to Australia with a family. This is the so-called resignation syndrome. I think that's a very good description of it based on the phenomenology that was described in Sweden, but that label was applied to describe these children. I think there are better descriptions of it. I'm happy to discuss that in the questions. Next slide. So I want to just now talk about how we can understand this sort of protracted immigration detention experience. And I'm presenting data here from a postdoc, Sandra Posadi, who did a study, a qualitative study, which is very close to publication. And these are the 3 key themes that she identified, interviewing asylum seekers who had been in immigration detention in Nauru, but had been transferred to Australia. They first described how they fled their home country, and that when they decided to come to Australia, they were prepared to risk their life because they believed they could arrive safely in Australia. And that expectation is critically important here. Next point. However, the experience on Nauru was an experience of deprivation, a lack of agency, exposure to violence and dehumanisation, and they determined that it was the Australian government, neither the Nauruan population nor the Australian population, but rather the Australian government as an authority that did this to them. Next point. And as a consequence of their experience on Nauru, they have felt and are now experiencing, they believe, is irreparable psychological damage to themselves. Next point. So just unpacking this, the description that they gave in my country, they torture your body and the rest of it, but in Australia, they kill your mind. And this is about them trying to flee their country to seek safety in Australia and prepared to undertake the dangerous journey that was required. The expectation of safety, refuge, and asylum is critical. Next point, please. This is the experience of material deprivation, the lack of agency, the dehumanisation and violence. I'll read these quickly because I think they're worthwhile. When we wanted to go to the toilet, even for the toilet paper, what they do is they took some of the papers and saying that this is your paper, we cannot give you more. We didn't have enough time to take a shower, maximum 2 minutes. There was not enough water. We might still have shampoo on our heads, but they would just turn off the tap. It was this dehumanization, this lack of agency, it was this exposure to vicarious trauma and violence and the dehumanization which people found most confronting and most traumatizing. Next slide. The final outcome was that people were completely destroyed, both inside and outside. Quote, "Now I don't know who I am. I lost myself because I'm not that person. I was that person who came to Australia. I was healthy, I was active, but I had a hard time, but I was happy. But now I can't laugh, I can't cry, I can't work, I can't study. I'm living in a very dark place." And this was in fact very similar to the quote that Omar Salih, the man who self-immolated on Nauru in front of the United Nations team, this was something that he had written prior to his suicide by self-immolation. Very similar. Next point, please. They felt that detention had destroyed themselves. They felt hopeless. The fear of depression, there's fear, there's depression, emotional numbness, lots of symptoms that I'm going to describe in a moment on my next slide. Because the types of psychological stress and trauma that people experience can be captured by what I've got here. So there's the dialectic of hope and hopelessness. And what I mean by this is that people have to maintain hope, even though they feel profoundly hopeless. They're completely disempowered, and that sense of powerlessness is very traumatizing for them. They feel that they can't do anything, and this is a very powerful influence on parents in trying to parent children in this type of environment. Over time, that powerlessness and helplessness destroys their resilience, and people give up on life. They don't give up on life in an active suicide way, although that happens in the way I described. However, people believe that life is not worth living, and they go through the motions of living. This is associated with a powerful loss of self-agency, which occasionally manifests as rage and indignation, in particular in the types of self-harming that I've described through self-immolation, cutting, attempted hanging. And of course, the cultural shaping that people bring to bear because of their cultural backgrounds. Next point, please. So the types of symptoms that we see are what I've described already: post-traumatic stress disorder and major depression. But I just really want to emphasize the importance of the cultural shaping of those symptoms. I'm happy to talk about that in the questions. The suicidality, which I've mentioned. In addition to that is the decay and the crumbling of hope. And we're beginning to see that now. So families are beginning to fragment, and we're beginning to see the emergence of violence. This is now 8 or 9 years post these people arriving in Australia with still no hope for resettlement or prospect of safe resettlement. We're seeing the paranoid persecutory psychosis that I described before emerging as their psychological defenses are destroyed. And then we begin to see the irreparable loss of functioning and skills. And I think, unfortunately, many of these people are not going to regain their pre-morbid level of functioning. And I'm, of course, very concerned about the intergenerational transmission of this trauma to their children. Next slide. So the children, we see, because of their terrible experience of losses, both in the stability and security of their parents, as well as the disruptions to their social and educational milieu, which becomes critical. We see high levels of anxiety, major depression, post-traumatic stress disorder, as is manifest in children of different developmental stages. We see separation anxiety, school refusal, poor sleep, night terrors, those sorts of manifestations of anxiety. Disrupted attachment becomes very, very significant. And as part of that, we begin to see some oppositional behaviours and attentional difficulties. A nice term is about the use of screen-based numbing that a lot of children use as a way of dealing with their fear, their terror, depressive and anxiety symptoms. Young children have learning delays, especially expressive language delay. Next point. And we also see the unfortunate emergence of suicidal ideation, intent and self-harming, which were in fact the reason why many of the children were removed from Nauru to Australia. And as I mentioned before, children 8 years down the track have finished school and now have no hope for education or vocational training, which has been extraordinarily despairing and dispiriting for kids who worked hard to try and do as well as they could, because they believed that if they did that, they at least could have a future, even though they felt their future had been lost for their parents. Next slide, which is my conclusion slide. So I think we have the refugee and asylum seeker may have persistent, repeated, but different traumas. The perception of trauma becomes personalized, but is different because it's generally externalized by the refugee and asylum seeker until their personal defenses are corroded. The expectation of protection is very important. Violation of that expectation is highly destructive. The individual impacts as a consequence of both those preceding factors are devastating. We get the mental disorders that I've described, but in addition to that, we get the corrosion of the people's individual moral structures. And we also get the impacts of this, I think, on our society more generally. The transmission of harm to children, I think, is very serious. And we're only beginning to understand that now, because this is really the first time this being asked, being examined. And of course, this is all dependent on national policy, which, if they were to be changed, might well have very significant beneficials in contrast to their very significant detrimental current impacts. And my last slide is my thank you slide, just to acknowledge the refugees and asylum seekers who've contributed to this study by generously giving of their time, the Cabrini Asylum Seeker Health Hub, as well as the researchers that I did the study with. Thank you, and have questions at this time.
So thank you very much, Suresh, for that very erudite presentation on such an important topic that's of interest to all of us who are working in the field of trauma. I'd heard you speak in the past, but today I understood the scope of and the range and the scope of the work that you've done and the contributions that you made to the field. There are a couple of questions, and I have a few questions from representing Spectrum as well. The first question, Suresh, is to expand on the resignation syndrome. Whether you could,
Yes.
I think you spoke about the alternative ways of describing it. So there's an interest in that from one of our
Yes.
clinicians.
So I think this is a really important point, and I think we really need to do more work to understand this. But the resignation syndrome, as it was described in Sweden, was very much considered to be an attempt by children to assist their parents and themselves in being able to gain refugee protection in Sweden. And so there was a description that this was a deliberate attempt by parents to influence their children's behaviours in order to achieve a particular political social outcome. And the treatment that was determined in Sweden was to in fact remove children from their parents. What this was observing in the Nauruan population, or what I observed in the Nauruan population, was not that at all. When I say Nauruan population, obviously the asylum seeker population there. What I saw was an increasing despondency and despair in the children, which began to manifest really as quite significant and severe depressive symptoms. And that what we saw in the children was almost a catatonic type depression, which of course was associated around the social construction of that depressive illness, because they recognized the fact that if they were to move to Australia, that things would be better. Parents didn't participate in that process, as far as I was aware. They didn't contribute to that process. And in fact, parents were extraordinarily distressed by what they saw in their children. And in fact, if you were to intervene in the way that the Swedish authorities or profession did by removing children from parents, I'm sure we would have seen deaths. I'm sure that parents would have suicided. I'm sure that children would have become absolutely distraught at that prospect. So that's why I think that there is a phenomenological difference between what has been described as resignation syndrome in Sweden and what we saw in Nauru.
So thank you, Suresh. I would encourage people to ask questions on the question and answer icon if you want to type your questions. Suresh, the resignation syndrome that you speak of sounds like some of the syndromes that we see in young children who've experienced long-term complex trauma. We tend to see them as adults usually, but during childhood, they describe somewhat a very similar syndrome. My question is, in terms of complex PTSD and complex trauma-related disorders, is there any understanding of the prevalence of that and within the refugee population or people who are in detention?
Yeah, look, I think that's exactly the type of question that we need to answer, Satya. So what I'm very conscious of is the types of trauma that these people have experienced is really fits under the mantle of what we might term complex traumas. And what we don't know yet are what are the consequences. Is this going to be comparable to what we see in adults who've been exposed to similar types of traumas as children in sort of mainstream Western populations? I made comment in my conclusions that the experience of the trauma is a bit different, and the experience is because in the types of patients that end up with personality dysfunction as a consequence of complex trauma, there is a very strong link between the individual as the victim and being exposed to the violence or the trauma. So people are sexually abused or physically abused in a very personal way. Whereas the type of trauma that they're exposed to here is more externalized. And so it's done to a group of them. And even though the experience is a personal experience, there is the ability to externalize the trauma to the group and to attribute it in a non or impersonal way. And whether or not that subsequently influences personality development remains to be determined. I think very important questions.
Thanks, Suresh. Next question is somewhat political. Feel free not to answer this question if you don't want to. So we are due to have a statewide trauma service. Do you see a role for the trauma service to work with some of this complex trauma conditions that might be present in asylum seekers and people who are in refugee detention centers?
Yes, I'm very happy to take on a political question like that, Satya, because I think that there really is a very important component of the statewide trauma service that needs to examine the breadth of trauma that exists within the Australian and Victorian community. And Victoria takes the lion's share of asylum seekers and refugees, and that's because we've got a very multicultural community here in Melbourne. So I think we really do need to have a component which focuses on this type of trauma and understanding in the way that your question has just posed, how is it that people are affected by these traumas, both as children, but also as adults, both within the migration trauma and the post-migration space.
Thanks, Suresh. As you know, Spectrum has an interest in the statewide trauma service. I see a lot of parallel with the complex trauma amongst refugees and people, especially people who are in detention centers. And it was really shocking to hear some of the statements that you made about people struggling to get toilet papers and not having access to showers. That is really shocking, happening in Australia. There is one more question. The question has come as a text to us because I think someone was having difficulty putting it on the question and answers. I'll just read it out. I'm curious whether Suresh has some thoughts on why our policies block asylum seekers from language classes, vocational education, employment opportunities, etc. This seems designed to make their lives intolerable and really hinder their transition to building their lives in Australia.
So the questioner, in fact, has answered the question. The reason is a deliberate attempt to not allow people to resettle. So it is about trying to send a clear message that you are not welcome and that we don't want you to come to Australia, and that message is both for the people who are currently in Australia, but any prospective asylum seekers. So that it's designed to try and communicate a message back to source countries to say, don't come to Australia as an asylum seeker, because we don't want you and we're not going to facilitate your life in Australia.
Thanks, Suresh. A couple of more questions. What are the best evidence-based approaches to address complex trauma in asylum seeker? What can be done to ensure they have access to services?
Yeah, so the first question is that we don't really know. One of the challenges that we've got is that a lot of the methodologies that we use with post-traumatic stress disorder, for example, aren't as effective, and a lot of the psychological therapies and the combined psychological and pharmacological therapies haven't been tested. And we're really using evidence from other sources, such as what we heard this morning, for example, in this population, and seeing whether or not it works. There's also some evidence for EMDR, which appears to have some benefit, and there are evidences for other types of psychological therapies, for example, narrative exposure therapy is another example. However, we don't have really good quality data. The other question I would make is that, generally speaking, people tend not to respond very well whilst they are in the midst of their trauma. And so what we have is this rather unusual situation where people are continuing to experience these chronic traumatic stresses, and we as health professionals are trying to make them better or trying to treat them. Second part of the question around the service provision, technically Victoria, and in fact most of the other states, allow asylum seekers to access health services that are state-run health services. The Commonwealth has a different approach, different attitude, but state governments have, generally speaking, permitted asylum seekers to access emergency treatments, and Victoria is pretty good in that regard. However, the problem remains that we need to have some asylum seeker specific services, such as the Cabrini Hub, which we set up in Brunswick, the Asylum Seeker Resource Centre has a refugee health service in Dandenong, which also looks after asylum seekers. And there's also a Victorian Refugee Health Service, which has clinicians working across the state addressing asylum seekers and refugees.
So thanks, Suresh. Probably the last question. So you mentioned stats saying that, especially in the Nauru Detention Center, self-harm, the prevalence of self-harm can be 200 times more than the general population. And nearly a quarter of the people who are in detention seem to self-injure. At the Melbourne Detention Center, we do, at Spectrum, we get called on to work with people who are highly suicidal or self-injuring repeatedly. Generally, our efforts have been, efforts to help them out has been very challenging, given the real life hopelessness that they have, and trying to do psychological works seems very, very challenging for us. Do you have any advice for Spectrum, how we can help them out?
So you're very correct, Satya. Working, as I said, with people who are in the midst of their trauma and continuing to experience their trauma on a daily basis, trying to put them in a psychological framework is nigh impossible. Rather, what I do and what I, when I talk to the registrars and the other clinicians about doing is that function there is to contain hope for people. And what I mean by contain hope is that you're a vessel of hope for them. That what you try and do obviously is to maintain an authenticity in your relationship with them, and that you present yourself as someone who will travel by their side through their journey. And that's just about all that one do. But that authenticity of the therapeutic relationship and the openness and honesty of that relationship in a psychotherapeutic sense with the individual, people find helpful and comforting. Not everybody, of course, but most people will find of some benefit and value. And ultimately, health professionals end up being the only people that many of these asylum seekers will trust, even though on many occasions that trust has been violated. If you can present yourself in a trusting, honest, open way, that can be very therapeutic.
So thank you, sir. Thank you very much, Suresh. So thanks a lot for that wonderful presentation. Thank you.
Thank you.
Before we break for lunch, we have a very exciting task, that is the launch of the Spectrum's Personality Disorder and Complex Trauma Research Center. This is in recognition of the fact that Spectrum has had experience in working with people with complex trauma over the last 22 years. We have focused our attention predominantly on people with personality disorders, which we'll continue to do, but we would like to also expand on to the researching and working with people with complex trauma disorders. So over to you, Suresh, to officially launch the center. Thank you.
Thank you. Thank you, Satya. In fact, this is really, as I mentioned, a very, very auspicious day, because I think it signs a transition point for Spectrum. The launch of the center will allow Spectrum to take that next step. It's principally, up until this point in time, being a service which has focused on providing clinical services to a population in Victoria that are as marginalised and as excluded as any population, like the asylum seekers that I've just been talking about. And these are people with significant and severe personality disorder. I remember as a registrar, 2 decades ago, how disparaging the mental health system was towards people with personality disorder, where it was used almost as a term of abuse, a term of exclusion, a term of denigration. And it's really been the work of people like Joe Beatson and Satya Rao over the last 2 decades with the establishment of Spectrum, and of course many other clinicians that have worked within the service, that has seen the transformation of what has become, what was a pejorative term into an illness which requires the same levels of compassion, kindness, respect, intellectual and scientific rigor and application as any other illness, both physical illness and mental illness. And Spectrum, in delivering those clinical services, has been able to transform the care of these people, I think, in Victoria. And I think it's a great testament to the leadership and the clinical team at Spectrum that they've been able to do this. Today, however, I think having done that launches a new era for Spectrum. And that new era is about the transition from a clinical service to one which has a longer lasting and broader reaching set of implications, both for Victoria, but I think also nationally and ultimately globally. What this new centre will allow is the development of educational programs, of curricula, of training to enable clinicians to acquire the necessary skill sets to manage and treat people with complex trauma, with personality dysfunction, in a way which is appropriate, which is evidence-based, and which is informed in the way that we want people to be treated. And secondly, it will allow Spectrum to engage in research at the highest level, to engage in the type of innovative work that is required to develop new treatments. We heard in the talk before the tea break about how only 50% of people respond to psychotherapy, and that's a good outcome. But that's not good enough. We need to determine what treatments work for the other 50%. We need to determine the types of treatments that are effective for the populations that I've just discussed. We need to determine how is it that we can intervene early to prevent these types of illnesses from developing? This is the type of research and innovation that Spectrum is ideally placed to undertake. I think that Spectrum should be a front runner for the new statewide trauma service, and in doing so can build on this extraordinary clinical base to become a service that has the potential, as I said, to be both a national, but I think should be striving to be an international player in this space. And I think the capacity and the willingness and the quality of the staff in Spectrum, and I think with the right leadership and the right support from the Department of Health and from Eastern Health, I think in partnership with appropriate academic institutions such as Monash University will enable Spectrum to take the step forward to a global leader. And so it gives me great pleasure indeed, to open the new centre in anticipation of the goals that it may seek to strive to achieve in the coming years. So thank you, Satya, for this wonderful opportunity to do this.
So thank you very much, Suresh, and thanks for your vote of confidence in Spectrum and your ongoing support. Thank you.